Good morning, ladies and gentlemen. I'm Kim from Korea. Today, I will present about the title, Should we abandon gastric bands? Based on our 10-year experience about explantation of adjustable gastric bands. We have nothing to disclose. Like other Asian countries, in Korea, obesity also has reached epidemic proportions. According to the national surveillance in 2016, the prevalence of obesity in both male and female much more increased recently. Studies on the effect of non-surgical treatment options for obesity rarely extend beyond 12 months. Bariatric surgical procedures are known to achieve substantial weight loss and provide major secondary health benefits, especially in the long term. Due to its technically ease and safety and adjustability, and gastric band has been one of the most popular bariatric procedures. And unlike gastric bypass sleeve gastrectomy, it does not alter GI tract anatomy. However, in the long term, slippage, infection, and migration are the major causes of band removal. And additionally, we have witnessed disturbance of food passage and proximal dilatation of the bands, so namely superior pouch in patients, even they have not clear complications such as slippage or infection. The higher than expected rates of complications and the operation have resulted in a loss of favor of gastric bands. In this graph, American College of Surgeons NSQIP 2014 data, the gastric bands dramatically decreased between 2010 and 2014. And at the same time, sleeve gastrectomy is increased dramatically. Results regarding the long-term incidence of gastric band explantations are contradictory. The most published series have reported that about half of gastric bands are explanted in the long term, for example, longer than 10 years. However, O'Brien reported that only 5% of bands were explanted 10 years follow-up, and their number of patients were very large, more than 700. And they concluded that from their data that the need for revision decreased as the technique evolved. So they emphasized the running curve effect. In the current presentation, we investigate the incidence, types, and causes of gastric band explantation over 10 years of clinical practice. In addition, we evaluate morbidities associated with explantation by different gastric band complications. This is a retrospective review of prospectively maintained data of the patient that underwent gastric band explantation as by single surgeon at a single tertiary center. The guideline of Asian Consensus Meeting on Metabolic Surgery regarding BMI criteria for AGB implantation were followed. We adopted past Plasta technique and various band makers were used, such as wrap band, Swedish band, the mid band. Band were left empty for 4 to 6 weeks after operation, when it was incrementally inflated over 3 or 4 sessions under radioscopic control in a radiologic chute. Subsequently, depending on the body weight changes, food portion size, and hunger, small volume adjustments were performed without barium swallow. Barium swallow test or gastroscopy was performed whenever there was clinical suspicion of complication, such as slippage or erosion. The definition of gastric band complications are follows. Slippage SL group consists of patients diagnosed to have acute and chronic slippage with abnormal pi angle by upper GI barium swallow study, not corrected by completely deflating the bands. Dumb band erosion, BE. The BE group consists of patients with moderate to severe symptoms attributable to intragastric band migration by endoscopy or infection of the band system by abdominal CT. Intolerance, IT. The IT group consists of patients exhibiting functional or psychological intolerance. Functional intolerance was defined as partial or total food intolerance. Usually, a patient having band intolerance has moderate to severe esophagitis by endoscopy or pouch esophageal dilatation by upper GI without definite evidence of slippage or erosion. And contrary, psychological intolerance, the three characteristics were observed. The first is their proper band adjustment was not possible because the patient was concerned they could not tolerate band tightening. And secondly, this patient often requested gastric band explantation for fear of future complication. The last three, but had no sign or symptom of esophagitis, and radiologic studies revealed normal pouch esophageal morphology without evidence of slippage or band erosion. Patients that underwent band-to-band revisional surgery, that is, removal and immediate replacement, were not included in the present study because we consider the latter patients maintaining their weight loss with their inside band or different from the patients having AGB explantation. This is the flow chart showing the management of adjustable gastric band patient. Between January 2009 and October 2018, a total of 267 patients underwent primary AGB implantation at Gachon University Gill Medical Center. And of these patients, 99 patients equals to 37.1% of the patient underwent AGB explantation. 4 patients were lost follow-up and their status were unknown at the time of this presentation. And there were 164 patients had their band in situ. Among those patients, band-to-band revision was performed in 9 of the patients, and among the 9 patients, 3 cases of AGB change due to systemic leaks and 6 cases of AGB explantation and immediate replacement due to acute and chronic band slippage. We also excluded in the analysis of the patients who underwent revisional sleeve gastrectomy with the concurrent AGB removal because they are beyond the scope of our presentation. So in the number of patients in the gray rectangle indicated the patients who were dealt with this presentation. Among the 99 patients who underwent AGB explantation, there were 13 SL patients and 39 BE patients, and there were 47 IT patients. And after excluding the patient who underwent revisional surgery, the isolated AGB explantation was performed in 82 patients. The SLI means isolated slippage. The BEI means isolated band erosion. ITI means isolated band intolerance. This is annual incidence and trends of adjustable gastric bands implantation or explantation over the study period. As you can see, the numbers of primary AGB implantation peaked in 2012 and then began to decline. Number of patients that underwent AGB explantation or conversion increased annually over the 10-year study period, and in 2015, the number of AGB explantation procedures started to exceed the number of implantation. This is the graph about demographic and anthropometric data of the patient at the time of band explantation. In this graph, as you can see, age and gender were not significantly different between SL, BE, and IT group. However, in IT group, namely band intolerance group, the BMI loss and total weight loss after primary AGB implantation was much smaller compared to SLBE group, and this is statistically significant. And the pre-removal health status defined by ASA criteria were not significantly different among groups. And in IT group, the follow-up period from band implantation to explantation was longer than SL and BE group, although significantly not different. This is a graph about annual case number of AGB explantation according to the etiology. SL means the patient underwent band explantation due to slippage. BE means band explantation due to band erosion. IT means patients who underwent band explantation surgery due to band intolerance. As you can see, there is high incidence of band erosion patients in the early period, and as time goes by, the patient who underwent band explantation due to band intolerance increased. This is a table of peri-op data of patients that underwent isolated AGB explantation. Patients with BE group showed significantly longer operation time and longer hospital stay. In terms of band removal method, 23.1% patients underwent transgastric approach, that is, short gastrotomy and division and removal of gastric band and closure of gastrotomy. There was significantly higher incidence of complication in BE groups. In about half of patients of BE group, antipyretics were used for post-op spiking fever. There was one patient having 3A grade complication who underwent PCD insertion for intra-abdominal abscess after removal of eroded gastric band. And there were 3 patients having 3B grade complication who underwent laparotomy or laparoscopy for intra-abdominal abscess. And finally, there were 2 patients having 4 grade complication, 1 septic shock and 1 hemorrhage shock. And taken in total, in terms of Krabbe-Dindo classification, there was significantly increased incidence of complication with minor or major complication in band erosion groups. AGB has been advertised as being designed for long-term use and to be reversed or removed if desired. However, during our initial 10-year experience, we found that 37.1% of bands has to be removed for slippage, erosion, or final intolerance. Furthermore, none of our 47 patients of band intolerance desired explantation, but band removal was necessary due to incapacitating symptoms irrespective of their desire. Is gastric band a safe surgical option? We found explantation of an eroded gastric band we associate with longer post-op hospital stay, high serious morbidity rate, and high percentage of intensive care unit admission, and these are in line with other studies. Overall, the better outcomes achieved by sleeve gastrectomy in terms of weight loss and mobility have contributed to its popularity and accelerated the decline in AGB surgery over recent years. Today, sleeve gastrectomy is the dominating procedure in our country, followed by gastric bypass surgery. So our conclusion is, during 10 years of clinical practice, about 1/3 of our patients underwent NGB explantation. The most common indication for band explantation in the long term was band intolerance, and this was followed by band erosion and slippage. Intra-abdominal abscess and intragastric bleeding were rare but serious complications after removal of eroded gastric bands. Should we abandon gastric bands? I think the answer is yes or no. It depends on surgeons' familiarity of techniques and apt care of gastric bands. Although the results of our study do not discourage AGB use, potential candidates should be informed of the long-term high risk of the need for band explantation and its associated serious morbidities. Thank you.